Hey, what's up, everyone? Welcome back to the Fat Muscle Project podcast. I'm John Gorman, your host. Today, we have got a show lined up for you. I've been waiting for this for a while because I'm just going to be honest. I need to learn. So this show's not for any of the listeners. This is for me. It's for me, bro. So, in all seriousness, Lisa and I have been talking about this topic for a while, and we were super excited to be able to get Dr. Carrie on the show. Dr. Carey, welcome to the show. And I've got a really quick question for you.
Yes.
How long have you been in the menopause space? If I can phrase it that.
Oh, yeah. So first of all, thanks for having me. And I've been a doctor for 21 years.
Mhm.
And when I was in medical school, my attending was in her 40s. And so I learned about perimenopause and menopause right from the get-go. So when I was in private practice, I did a lot of perimenopause, menopause care. No, I did the whole gamut. I did a lot of fertility, a lot of PCOS, a lot of PMS, things like that. But I had a lot of women over 40 struggling and couldn't get help.
Yeah. And the reason why I start the show off with that is, Lisa, I would say, and I'll ask you because you've got a good client roster. I've got a good client roster. This probably now these days applies to probably 80% of the females I work with, I would
Mm.
say at this point. Because what about you? What do you think that, how would this apply to your roster?
Yeah, I would say that's probably quite accurate. And I mean, even if it doesn't apply to them directly, women might struggle with like a regular cycle, even if they're pre-menopause, or they might struggle with other things around hormone balance. So I think this topic is just so relevant basically to anybody, and even like the men listening to this. I would love for them to still keep their ears open because, of course, we all have moms or a partner or whatever, and even just in general, when it comes to understanding our hormones better, if you're listening to this and you're a male coach, I think this is going to be super valuable information for you too.
Yeah, it was. I want to just go ahead and draw people's attention real quick to the show notes. When you're done, go check out Dr. Carey's YouTube channel. We're going to link it here. That's where I learned everything. And that's where I was like, we've got to get her on the show. I think it's a great introduction. You've got a lot of different videos on there. So if you want to talk about your YouTube channel, you put a lot of time and energy into that. I
Hmm.
think it's one of the best out there as far as educating people. And you don't ask for anything, you're just helping people. And I love that.
Yes.
Like, that's how we roll. So talk about your education on YouTube.
That is definitely a big, huge passion of mine is just to give and give and give for education because I figured out a long time ago, all my patients would tell me, like, I never learned this in school. My health class was taught by the high school football coach. So you could all imagine how that went when I was much younger. And then when I got into hormones, I found hormones were very second nature to me. I understood them. I loved them. I appreciated them. But I had a lot of women go, I just didn't know that. Like, I didn't know that's how my body worked. I even had that hormone. I didn't know my anything around fertility, pregnancy, perimenopause. And so it became a huge passion. And in YouTube, it's so great because I can just talk to the camera for, 15, 20, 25 minutes in these easy bite-sized chunks of time where I can explain a concept, I can explain symptoms, I can explain the questions that I get, I can explain hormones. And the great thing is, I am the type of doctor that I have been in the herbal world for a long time, the supplement world for a long time, even the woo-woo stuff, homeopathy, and people roll their eyes until it works, and I'm like, well, just try it and see if it works for you. And then they're like, holy crap, that worked. I'm like, I know, I've been doing this a long time. And then so it gives me a nice space, a nice landing pad that I can talk about all this and then get in the comment section and continue to answer people's questions.
Yeah, that link is in our show notes, along with all of the links to all your socials and contact information. So, Lisa, why don't you go ahead and take the reins as you do so well, and let's get this thing kicked off.
Yeah, I would love to start off with simply like an explanation of what is menopause and what are the various stages to it.
Yes. So menopause is interesting. Menopause is actually one day. So we have our reproductive cycling years. That's called premenopause. Then we have the transition time, which is called perimenopause. Some people call it the menopausal transition. Once a woman, if she still has her ovaries and uterus, once she goes 12 consecutive months with no period, that 12th month, day 365, congratulations, you get a crown and a party. You are considered menopausal. You walk the door of menopause. And then after that, you're postmenopausal for the rest of your life. Like there's no more reproduction, there's no more period. Your hormones have all changed. It affects every single system in your body, not just the reproductive, not just your uterus. And then of course she lives the rest of her life. So when we're talking about stages, we have those stages, how we move from reproductive to transition to the doorway to postmenopausal. But even within that, in perimenopause, we have stages in there. We have an early stage and we have a late stage. And people really like to wrap their heads around this because for some women, perimenopause can last 10 years. And so they're like, what the heck? I'm having all these changes. Like, where am I? How much longer do I have to go? It's kind of like having a little bit of a roadmap. So if they tell me their symptoms and like we can figure out where they are, I'm like, okay, you've moved from, early to late, you're getting closer. Or for some women, I'm like, oh no, girl, you're just starting. Like you're in the beginning. Let's help walk you through this.
Yeah, this is super helpful. I think just in general, knowing that it's not like menopause itself is literally just a day or like
Mhm.
one particular point in time, and then having that outline of, okay, well, the duration of each phase is different for everybody, obviously, but it can take a while. And simply also acknowledging that the menopause transition is not the same in the beginning as it is in the end.
Yeah.
And so I guess specifically talking about perimenopause, maybe we can go into that a little bit more.
Yeah.
What are some of the first signs that might indicate that a woman is entering perimenopause?
The average age that for perimenopause is early 40s. That's when she kicks off. Now, some women will go through in their late 30s. They'll start in their late 30s, which I understand you will see in the medical research and you'll hear doctors go, "Oh my gosh, they're 30s. That's way too young." But I've actually had women say to me, "Oh, my mom went through menopause at 44, at 43, at 45," which means it makes sense that at 38 they were having symptoms because, not that much longer they went through the doorway of menopause. Whereas the average age of menopause, so no period for 12 months, is 51 or 52. So it's this broad amount of time where you could go through. But I'd say on average, women are in their early to mid 40s when they start noticing symptoms. When we're talking about research and categorizing early and late, they technically call early perimenopause is if your cycle has changed by 7 days. I didn't create these rules. If I was there, I would have argued a little bit more on this, but I find most women notice their cycle doesn't change 7 days right away, but it changes maybe 3 or 4 days. Such as they used to be a 28-day girl, and now they're like, what the heck, I'm 25 days or 26 days, and then that becomes their new normal. And because of these shifts, the first hormone that tends to decline, the first major hormone, is progesterone. And what they'll say to me is, I can't sleep like I used to. I'm more tired. I'm having more mood swings. I'm either more depressed, more anxious, more impatient, more rageful, or all of the above. Like they're having all these symptoms. They might start to notice again changes in their cycle, such as like cramps are less or worse. Their actual flow is heavier or lighter. Their cycle is shorter or longer. So they used to be consistent-ish, and now they're like, things are starting to subtly change. I'm noticing this. Now, the hormone estrogen, estradiol, which is our main estrogen, will start to change as well. It's not as radical as progesterone, but it can. So some women may notice like, I'm getting some brain fog, or I'm noticing my migraines are worse, or my joint pain comes and goes. So they start to have these other symptoms related to estrogen as well. Now that's early perimenopause. For some reason, they don't have a middle. I feel if I designed it, I would have a middle stage, but we jump right into the late stage. And the late stage is where you've skipped 2 periods at least. So 60 days, no period, which seems like a big jump for me, but here we go. Now, when we move through this, now estrogen is being more erratic, meaning the highs are higher and the lows are lower. And this is when women are like, okay, now I'm really feeling the estrogenic symptoms. So again, mood could be more significant one way or the other. Sleep, estrogen totally plays a role with sleep. So maybe they got their sleep under control and now insomnia is back. The joint pain, estrogen is lubricating. So they're like dry eyes, dry mouth, dry skin, dry hair, dry joints. dry vagina. They'll have vaginal symptoms, right? They'll start to notice blood sugar issues. I'm sure you two work with this all the time. Women go, I've put on 15 pounds and it's
Yeah.
all around the middle and I didn't change anything. Like, I swear to you, I eat healthy, I eat clean, I hit the gym, like, I don't drink. In fact, I can't drink anymore because I can't tolerate it. What happened? Why did I put on these 10 pounds, these 15 pounds? For some women, it's 20, 30 pounds. That seems to come on pretty quickly. And it's that estrogen that plays a role in all 12 systems of the body. So you can see that these symptoms can be a little different early from late. So some women might be like, "Oh, I used to have the sleep thing. I don't have that anymore. But now I have the joint pain." Or I used to, right? I used to have the anxiety. I don't have that anymore. That went away. But now I have the hot flashes and I've put on 15 pounds. Because again, these hormones affect every system in the body. It depends on the woman. And it sort of depends where you are in this whole transition and what's going on in your life.
So I want to jump in with a real quick question here. I had this put in the show notes for later, but I think it's appropriate to talk about now. So all those things that you talked about, like from a guy's standpoint, when I'm dieting females, and it doesn't have to be to get stage lean, but if it's pretty hard dieting, right?
Hmm.
They see some of these symptoms anyway, and maybe they're 28 years old, but they're seeing the progesterone drop, right? Because cortisol's high. Dieting
Yeah.
is very, very hard on the body, and they're seeing these things happen. How is cortisol tied into entering these stages? And if a female has a dieting history, because unfortunately, females just have it so hard where you're
Right.
constantly having to be compared to everybody else on social. And it's like everyone feels like they have to diet all the time. I've seen a lot of females start to enter menopause a lot earlier if they've got a long dieting history. Would you agree
Hmm.
with that? And then how's cortisol kind of tied to some of this?
I definitely, again, we don't have the research to prove it, but anecdotally, just, like you and me doing this a long time, I've noticed observation, the higher the stress, they tend to go through earlier. Now, I don't have a book or a manual that would tell you when you're going to go through the active menopause. But if you happen to know, like, let's say your mom or your aunts or your older sister, let's say in general, the women in your family go through at 50, but you have had tremendous high stress. I see it with autoimmune disease and in particular autoimmune thyroid, but it doesn't have to be thyroid like Hashimoto's. It could be other autoimmune. They tend to go through earlier. Again, I'm just comparing off what I know with their family or what we were kind of expecting. They tend to go through. And with the stress, and then you said dieting, but with the stress, I find that the Gen X, the elder millennials, were what's called now that sandwich generation. So we might have kids either still in school or at home or going off to school. We're at the peak of our career. Our parents are aging. So we're dealing with the fact that, like, maybe you're trying to downsize mom and dad's house. Maybe somebody's really sick. Maybe somebody broke a hip. Maybe we're managing medications or, as our parents are getting older. And and then like world stress, day-to-day stress.
Yeah.
And then their body is changing. One of the biggest stressors in the world is lack of control. And for a lot of women entering perimenopause, they are so used to being in tight control of their life. They're in control of their kids' schedules, their family schedules, like everything that goes on in their job or stay at home, like they have it dialed in. And then their body goes, "No, you don't. I'm going to change everything." And they're like, "No, I can control this harder. I can work harder. I can do all the things." And the body's like, "I'm just going through this natural transition." Like perimenopause is not a disease. It can feel like one, but it's not technically a disease, right? But that's really stressful to have the rug. It's for a lot of women, it feels like the rug is pulled out from under them.
Yeah. And I think and this might be a dumb question for people that know, but I'm just going to ask it. If a female is chronically dieting and their progesterone stays chronically low, maybe from the
Yep.
age of 28 to 30, is low progesterone from stress and dieting and stuff like that, is that something that can maybe have her enter the stages a little early? Is progesterone kind of a first sign, I guess, because I'm looking at it from a very broad perspective and I'm not an expert.
Right. So perimenopause, menopause actually is all about signaling and how many follicles she has left. So a woman is born with all the follicles, it's like she doesn't make anymore. There is some very cool, very nuanced research about stem cell therapy and helping women create new follicles. And a follicle is basically the set of cells that surround the egg. and they live in the ovaries. So she's born with millions, and then by the time she hits puberty, she's got like hundreds of thousands, and then by the time she's perimenopausal, she loses 1,000 plus every month just because of natural aging and ovulation and things that happen in the ovaries. So if she gets to a point where she's so much stress, so much maybe let's say disease, metabolic disease, things like that, that's impacting the follicular health. There's like in 2017, I want to say there was a paper, the theory of aging around reactive oxygen species and in stress. And it was like the ovaries are really sensitive. So the more stress, chemical stress, metabolic stress, any kind of stress that's happening, the lack of antioxidants in the ovaries, it's going to progress the aging of the ovaries faster. And that has only gotten more research behind it. Last year, this year, the year before, like we're really seeing some interesting research on like, yikes, the mitochondria, they get hit really hard in the ovaries. The ovaries are very sensitive. So if she has a history of not being the healthiest, dieting a lot of exposures, then it only makes sense that those little follicles being so sensitive go away faster than somebody else. And so I definitely can see it. So I don't think it's not the lack of progesterone, like that single-handedly isn't it, but it's what has caused the lack of progesterone. And then what is that doing to the health of the follicle that's supposed to make the progesterone and release the egg? So when we back up, it's a broader picture around this whole, in a sense, it's like a mitochondrial theory of aging, but it's all around free radicals and reactive oxygen species and toxicity that impacts the health of the poor little ovaries that are just trying to cycle. They're just trying to pop out an egg and do their job and make hormones.
Sense now. Yeah, thank
Yeah,
you.
and it's very similar in men. Men's testicles are very sensitive. They can barely handle temperature change. They don't do well with chemicals themselves and environmental toxicants, heavy metals. We know like high stress can impact lack of sleep. If a man doesn't sleep, if he gets only 5 hours of sleep, we know his testosterone starts to decline. So his testicles are just as sensitive as her ovaries. The difference is, unless something, serious intervenes, he can keep making sperm forever and ever, whereas she's only born with a finite amount of follicles. And it's those follicles that make the hormones, help the cycle. And then once it's gone, it's gone.
Excellent. Yeah.
So we spoke about estrogen, we spoke about progesterone, and now also cortisol and so on. I'm curious about the role of testosterone in this whole picture. What happens to testosterone? Because of course, a lot of the people listening here want to build muscle or at least preserve muscle mass as they can when we are aging. So I'm curious about that.
So testosterone is made a couple places in the woman's body. So it's made in the ovaries, it's made in the adrenal glands, which are the two little glands that sit on top of the kidney and help manage saltwater balance and stress response and all sorts of things. And then it's made out what we call the periphery. So the body can make testosterone like just floating around as it needs to. So we have three places as women can make it, whereas men, like 95% of your testosterone is made in one place, the testicles. That's it. So what happens with testosterone is that it can decline if there's something going on in the whole adrenal system, the HPA axis. We can have issues with testosterone, of course, when the ovaries are not doing that well or they're starting to lose follicles and shut down. So, but it's not an automatic in menopause. Some people are like, oh my gosh, women, of course you're going to lose testosterone in menopause. Not all women do. Some women lose it right away. Some women, it's a very quick decline. They notice it, they feel it, their libido's down, their motivation's down, they can't build muscle mass. And then others, it maybe 50, 55, maybe even 60 before they start to notice a significant impact in their testosterone. What I tend to see is that women who maybe were born with more robust levels, I don't mean high levels, I just mean more robust levels, tend to be more robust longer. So they may not lose it until they're, and I don't mean, but it's like a steady decline in their 50s. Whereas if you have a woman who just never had great levels of testosterone, maybe she just like never put on great muscle or never had a great libido, everything was okay-ish. they tend, in my observation, they tend to lose it faster. So we can't say testosterone automatically declines in the transition of menopause because it's not for every woman, but it can be for some women. So absolutely, when looking at hormone testing, for example, or asking questions like, what are your symptoms? Can you build muscle? How's your libido? How's your motivation? That can give you some pretty good insight because some women are still like, my libido's fine. It's great. I totally put on muscle. I'm like, all right, your testosterone's not a problem. And other women are like, oh, I don't have any muscle. In fact, I'm gaining weight, fat. I have no libido. I have no motivation. Like, I don't have any energy. I'm like, ooh, androgens, testosterone, let's check you.
That
Uh,
makes absolute sense. Sorry, I just have one more question that's not actually in the show notes when it comes to perimenopause or in general. If a woman is on hormonal birth control, how are the symptoms showing, or how is this impacting the whole picture of the
Yeah.
menopause transition?
So the birth control pill takes over. So most women are on a combination. So they're on a synthetic estrogen and a progestin combination. That's like the most popular. And because of its design, it shuts down the communication from the brain down to the ovaries. So she's not making her own estrogen and she's not making her own progesterone. And in fact, she can still make testosterone, her own testosterone, but the birth control pill actually drops that or decreases that for a lot of women.
yeah.
So they go on the birth control pill, they don't cycle. They will get what's called a withdrawal bleed. It's not technically a period, but they will get a bleed if they do the sugar pills, but they don't make their own hormones. So for some women, the birth control pill actually works well for them in perimenopause because it controls bleeding and can reduce symptoms pretty significantly. For other women, they'll get into perimenopause and they're like, you can still, as long as you make an egg, you can still get pregnant. So they're like, I don't want to get pregnant. I'm going to stay on my birth control pill. But then they'll start noticing like breakthrough bleeding. They'll start noticing hot flashes. They'll start noticing sleep issues. They'll start noticing joint pain. Even though they're on the birth control pill, it's just not what their body needs anymore. It's not working for them. And I'd say it's about 50-50 in my observation. The birth control pill is not my first choice for like hormone therapy, but obviously I know a lot of women are on it, like it, or don't want to be pregnant. So I'm just like, well, let's just watch it because if you do start to notice things are changing, the birth control pill may not be the right for you, or it may just be the wrong dose or type for you. So it's not a perfect method either.
Okay, yeah. Yeah, thank you for
Um,
that explanation, John. I cut you off. Yes.
no, it's okay. Just going back to testosterone real quick.
Hmm.
I think in our world, women are more apt to understand it because they're trying to build muscle and they're trying
Hmm.
to, do things physique enhancement related. I think generally it's probably the one that has the most fear behind it and it's the most misunderstood. Because I know, like, just even talking to family, they're like, why do I need that? That's a
Hmm.
man's hormone. That's this and that. How misunderstood do you feel like that is? And is that changing? Do you see
Yeah.
a shift? Because you've got your hand on the pulse of this whole thing.
Yeah.
So you're seeing it from all avenues. Do you feel like that's starting to shift, maybe?
Oh, hugely. Thanks to social media. Yeah. It's not perfect, but definitely I have a lot of women that are saying, I'm on estrogen, I'm on progesterone, or I'm just on progesterone. Like I think I'm ready for testosterone. I'm ready. I want my libido back. I want muscle. I want motivation. I want all these things. The thing about testosterone in women is that we actually, molecule for molecule, we have more testosterone than we have estradiol, the main estrogen. Now, we have estrogen receptors all over, and estrogen, of course, is a massive part of what makes us, women. And like I said, it impacts all 12 systems, but we do have more testosterone. So we don't have as much as you do, and John, like we don't have as much as men do, but we definitely have a lot of it. And I think decades ago, because it was constantly marketed as a man's hormone, and it's especially when you're trying to just very quickly describe it to women, and you're like, testosterone, like the hormone men have, that nobody changed the narrative to go, well, you have it too, just not as much as a man, but you have it more than estrogen. Now, here's where it gets interesting. This is a little like clinical pearl. Women, everything's a ratio. Now, with her menstrual cycle, things shift a little bit every day. So if she's still getting her period And then, she goes through her whole cycle where these ratios shift all the time. And these shifts are very important for brain health and bone health and immune system and all to get pregnant, all the things. We have a ratio between testosterone and the main estrogen, estradiol. What can happen for some women, though, is that their estradiol drops faster than their testosterone. So I mentioned some women, their testosterone doesn't drop, but their
Yeah.
estradiol does. So now we have a bigger gap between the two. We have like the seesaw shifts towards testosterone. And what happens is, and the research is really fascinating on this, because women do have, of course, testosterone receptors, they're called androgen receptors, that there's a perceived androgen dominance. And it's almost similar to PCOS, polycystic ovary syndrome, in the symptoms. They haven't developed PCOS. It's just the symptoms. So these women are like, I am getting acne on my chin and the sides of my face. I'm getting hair loss. I'm getting hair loss at the temples. I'm getting hair loss at the back of my head. I'm really angry all the time. I'm getting weight gain around the middle. I'm getting an apple shape as opposed to a pear shape. So it's all these what we call excess androgen type symptoms, but it's not really excess. They don't have boatloads of testosterone. It's not high on a lab test, but it's relative to estrogen. Estrogen is what helps keep it in check. And so now we're seeing this research that's like, oh yeah, if you're starting to develop an apple shape, you're gaining weight around the middle as opposed to your thighs or hips or booty, then more androgen receptors are probably getting stimulated. And I will see this in real time because women go, I'm afraid of estrogen, that causes cancer. Just put me on testosterone. And then they're like, wait a minute, I have chin hair, I've got this belly, and I'm mad all the time. And I'm like, yeah, there's a discrepancy in your ratio. We have to keep that in mind relative to your estrogen.
Yeah, so that's probably a place where, HRT comes into play. And I know I'm jumping ahead, but just balancing that ratio and trying to get that to a good place,
Yeah,
right?
and there's not an actual number because people will ask me, like, what's the number, Carrie? If I divide one into the other, is it 3? Is it 2? Is it 46? I'm like, we don't have that data yet. It's more relative. When I look at your blood work or I look at your hormone work or just your symptoms, I can see like, ooh, you're starting to lean more androgenic. Like let's get some estrogen in there and redistribute, rebalance.
Yeah, I'd love to shift into post-menopause now. So we've gone through the
Mhm.
menopause transition, we hit the menopause day, and now we're entering post-menopause. Tell us a little bit about the changes there, what's going on with hormones or isn't going on with hormones anymore, and all the rest of it.
Yes, I wish at that transition point, the menopause day into postmenopause, I wish again, like I said, I wish we got a party, a crown, a watch, something, a certification, like, yay, you did it. But we don't. And so what happens is once the this there's no more period. Like, I mean, you've already been going 12 months, so you've been dealing with no cycle for 12 months. If you're not on hormones, then your estradiol levels and your progesterone levels are very low, because that signal isn't there from the brain anymore. You don't have the follicles to make it anymore. You're not ovulating, you're not reproductive. And so therefore those hormones drop quite low. You have other hormones that will increase. Hormones from the brain, known as FSH, follicle stimulating hormone. It's a good marker. Some women are like, how do I know if I'm, getting close to menopause? I'm like, oh, we can run an FSH. If it's above 10, then I know that you're getting closer. It's not a perfect marker, but it's helpful. There's another marker called LH. That's luteinizing hormone. It's the hormone that helps us ovulate. And again, when FSH and LH go higher and higher, it's the brain going, hello, do the thing. Hello, ovaries, wake up, do the thing. And the ovaries are like, no, I don't have any follicles. So she doesn't make any hormone. Now, she can still make testosterone. Like I said, we can make it in other places. So that's why some women go, why isn't my testosterone dropped yet? I'm like, well, 'cause maybe your adrenals are doing a pretty good job. Your peripheral, your other tissues are doing a pretty good job. We can still make a little bit of androgens out of our ovaries for a couple years after menopause. So if you're not on hormones, do expect your estrogen and progesterone to drop quite low.
Hmm.
And
Yeah.
that's I would venture to say I'm a positive of this, right? Like sexual health is going to just plummet, right? Your joints are going to feel awful. And I say all this to kind of tee up. I know where Lisa's getting ready to go with this, to tee up a lot of things. As we start to talk about HRT here in a minute, I know that that has to feel awful. Like the gym has to feel awful just in general, right? But we're talking
Yeah.
about somebody that's not having any hormones at all. And then to stay there. My mom, like that's what we saw. There was no hormone
Hmm.
replacement therapy. That
Yeah.
generation didn't know hardly any of that. It was super taboo or scary. They went through that with nothing. And I'm
Yeah.
like, I know what low testosterone feels like because I had that. And I'm like, I can't even imagine having low progesterone and estrogen if I was a female.
Right.
There's still people going through that. Like, that's crazy, right?
It's what's interesting is that for the longest time, hot flashes seemed to be what defined menopause, hot flashes and night sweats. So I would meet a lot of women who go, I didn't have any symptoms of menopause, none. And I'm like, really, none? And they're like, nope, I haven't have ever had a single hot flash or night sweat. I'm like, if you, but anything else, right? It could be obesity, it could be all the joint pain. And joint pain is actually now, we call it a syndrome. It's the musculoskeletal syndrome of menopause. It's so common that Vonda Wright and Dr. Vonda Wright and her group coined the term, did the research and got it published because they were like, it's so many women suffer from this. The vaginal symptoms, we used to call it vulvovaginal atrophy, which just means atrophy means shrinkage. And then they realized, oh my gosh, it's so much greater than that. It's genitourinary syndrome of menopause. It affects the bladder, the urethra, which is where the urine comes out, the entire vaginal canal, the labia, the clitoris, like every kind of tissue, the pelvic floor health. Like it was way bigger than just a little bit of shrinking away of some tissues. And now we know that the amount of women who are in their 60s, 70s, 80s, 90s developing urinary tract infections, developing sepsis as a response, ending up in the hospital because of it, all because of the lack of estrogen down in the genitourinary area. So it's true. These I do hear like, oh, I've never had a hot flash or night sweat, or I just gritted my way through it, but now I'm on the other side. And I'll say these: how do your muscles feel? How do your joints feel? Like how are you know how when is the last time have you ever had a urinary tract infection? What's going on with you just all the what's going on with your cardiovascular health? Do you have high blood pressure? Do you have high cholesterol? How do you feel like your brain is functioning? Often, not always, but often, one of those questions is like, oh, it's not good. Oh my gosh, my hip hurts so badly. Oh my gosh, I keep getting urinary tract infections. Oh my gosh, right? But nobody's piecing it together that these hormones play a major role in the development and progression of some of these symptoms because it's not classically, for decades, it wasn't classically thought of as a quote unquote menopausal symptom. It was like, oh, that's just what happens when you get older. It's like, well, for her, it's because of often because of the decline in these hormones, and then nothing was done about it. I mean, the amount of women who've had frozen shoulder and had no idea that's really related to changes in estrogen. Frozen shoulder is the worst. It lasts forever. It requires a lot of therapy and intervention.
Wow.
It like that'll derail your entire training program if you develop frozen shoulder.
Yeah.
But women don't realize it. A lot of women are like, just hot flashes and night sweats, right?
So I think that those are some really great pointers as to when someone might consider HRT. So you mentioned joint pain,
Hmm.
just in general, muscular aching. Obviously, we talked about lack of libido, etc. So someone's considering HRT now. What are some of the myths they might have picked up or heard about HRT in
Yes.
general?
Yes. Well, of course, the big one is like it's all bad, it's all dangerous, it all causes cancer. Like as soon as you go on HRT, you will develop cancer, and that all stems from a study, the Women's Health Initiative, that came out 20 years ago, 20 plus years ago, that made all the news and the headlines in the magazines that said that, and that is thankfully we got really good information out of that. And then we've had subsequent studies to be like, no, 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 it's not one to one. It's not that you go on hormones and immediately develop cancer. Like, that's not going to happen. In fact, unfortunately, women develop estrogenic cancers like breast cancer who've never been on hormones. Women who've never been on the birth control pill, they've never been on any kind of hormone. And God forbid, they develop breast cancer also. So, and we do know from the Women's Health Initiative, that one study, there was a subsection of that study where women were just on estrogen. They were just on a synthetic estrogen. And the outcome of that was those women actually had less cancer and a decreased risk in cancer. So we know that again, what was put out to the newspapers and the magazines and everything isn't one to one. Now, does it mean that a woman in general, like what's the number one risk of developing breast cancer? Being a woman, unfortunately, but it's not that go on hormones automatically it's a death sentence and you're going to develop. Most of the women that I talk to, yes, they can have these major symptoms, like you said, but in the beginning, a lot of them are like, I just don't feel like myself. Like, I'm sure you have clients that come to you that are like, man, I used to just be motivated and have energy and want to be around people. And now I just don't care. Like, I just don't feel like myself. And I'm just like, blah, and I don't want to do this. So it doesn't have to be these great, massive symptoms. Like, if somebody's listening going, well, I don't have shoulder pain and I think my libido is okay, and I'm not having urinary tract infections, and I haven't had a hot flash. But if you're just subtly like, I don't want to do this anymore, that
Yeah.
can be a big reason for hormones too, because it affects everything in our brain as well, like our brain hormones.
Mm.
There was the black box warning was
Hmm.
removed. It was like, I remember the day. It was like November 11th. I don't know why I remember that day, but that was a big day.
Huge.
What's that mean to someone like you when that
So,
happened?
oh, it's massive because they had a black box warning on any medication. Of course, we have a lot of them. It was not just hormones. It's basically when there's a major risk, potential major outcome, they have to put this literal black outline box that says, hey, if you take this prescription, like these really bad things could happen and you have to be aware of this. It's a public service announcement essentially. But unfortunately, they were putting the black box warning on everything. They put it on real progesterone. They put it on very low dose vaginal estrogen, like things. And they put every warning like, hey, if you go on progesterone, like you're going to get heart disease and you're going to get a clot and you're going to get breast cancer and you're going to, and these potential side effects are route related. So let's take blood clots for an example. Technically, they're called venous thromboembolism, VTEs. That's a blood clot. And it's if you swallow your estrogen, your risk for blood clot does go up a little bit. But it's swallow the estrogen. It's not the kind that you put as a cream. It's not the patch. It's not the vaginal. It's not even progesterone. It's one specific, but they gave it to everything. The same for vaginal estrogen. It's an incredibly low dose, usually, if that's how it's prescribed, that it doesn't really go systemic in the body. It doesn't make much difference in your systemic value. It's just for the vaginal area, vulvovaginal area. But it got all the same side effect risks, like you're going to die, you're going to develop cancer, you're going to get a blood clot. And everyone was like, oh, well, then I can't take this because I'm going to have all these major outcomes. And so it was a lot of educating and convincing and trying to prove to patients and clients, like, no, no, no. I know it's on there, but it's for the wrong reasons. So for the most part, I'm really glad that black box warning got taken off. I do believe, though, that the oral estrogen, the kind that you swallow, still needs some warning. Like, we still have to tell women, if you swallow your estrogen, you have an increased risk for clot. It's not a massive risk, but it is a risk. So you need to be aware of it. And then there's some other things that go with that. So I am thrilled they took it off the majority of things, but I'm like, well, we just swung the pendulum from one way all the way to the other. And I'm like, well, we still need some education.
Right.
So I'm going to ask a real quick question for my female clients because they ask me all the time. I am not the person to answer this question, right? So
Hmm.
when I am looking at their labs, we do have a telemed clinic, but I send them to like Jordan or Brandon. But when I'm looking on my end, I've got to, put their plan together based on their hormones because I'm not trying to put muscle on someone if they don't have testosterone, right? We need
Right.
to adjust that. So I might have that conversation, say, hey, I think you're a candidate for hormone replacement. Let's get you linked up and talk to Jordan, our MP, right? One of the main questions that I get all the time, hey, we have a family history of breast cancer.
Hmm.
Do I need to worry about that when it comes to testosterone? And I get that all the time.
Oh,
So
interesting.
now I'm going to point them to this and I'm going to say, well, let Dr. Carrie answer this. Or what would you say to somebody? And it's mostly related to testosterone. I never hear that with estrogen and progesterone, but
Oh,
I hear a lot of it with testosterone. But regardless, across the board, family history, worried about HRT. What would you say if someone was sitting in front of you asking you that right now?
Well, I'll answer the testosterone. The answer is no with testosterone. We don't have to worry with family history and testosterone. Although unfortunately, we don't even have an FDA approved form of testosterone for women. It's a very
Right.
neglected hormone for us. So
Right.
we don't even have a lot of great studies on testosterone in that. But what so far right now, we know that like if you go on testosterone, it's a little bit of testosterone. That's if you have a family history, like I don't worry about that at all.
Yeah.
Now, speaking of family history, though, in general, way back when I was young, my grandmother died of breast cancer. And back then, um, family history was front and center. It was a big, risk to know about. But now, my just having one grandmother with breast cancer, like they've long removed that. Like that's not a risk factor. If you have every woman in your family has developed breast cancer or died young of breast cancer, that is a risk factor. But if grandma or a great aunt or someone over there, your second cousin, that is not considered family history that you necessarily need to worry about anymore. And I'm really glad about that because, again, when I was a lot younger, it was like if there's anyone in your family, you have family history. And now they're like, no, 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 no. It has to be
Okay.
significant. And definitely, especially if it's young, it's like under 50, in particular, then so a lot of women under 50, that's like a real big red flag. But if it's your great aunt, your grandma, your great grandma, second cousin, like even first cousin, like I'm like, oh, that's not like, yes, you have that in your family, but that's not the family history we're talking about. Not anymore. We've learned so much since that time.
Thankfully, yeah.
Yeah.
So, okay, let's say someone is ready to go on HRT. What are some of the, or like, how can someone's quality of life improve if they go on one, two, or all three, a combination of the three
Yeah.
hormones?
I would say I've scoured both research, I have scoured the comment section, I've been all over Reddit. Like I've been across the board from the scientific to the not scientific at all. And I would say overwhelmingly the women who are on hormones, especially hormones coupled with all the lifestyle factors, will say they will stand up on their soapbox and say, it has completely changed my life. I am a whole new person. I will never go off of these. You have to pry these out of my cold, dead hands. It doesn't mean they can't have side effects. It doesn't mean it doesn't take a minute to figure out which dose and right is right for you. It's just like anything in life. Like we may not nail it on the first try. You may hate the route we choose or the dose you choose and get side effects. We just adjust, hang in there. But I'd say the majority of feedback is super positive. And just as you said, I love that you said if you go on one, two, or three hormones, even four hormones, because there's DHEA. But I love that like women have control over this. Let's say you're really nervous and you're like, I don't want to jump into all of them. Don't. Start with progesterone. That's the one that goes down first. Let's see how you do. And then you can like drip these in. We can start at super low doses. There's so much we can do to help you feel comfortable, to meet your goals, to like get the outcomes that you're looking for through hormones, but then also lifestyle. And John, you mentioned this early too about like you don't want to put muscle on somebody with no hormone, but also I don't want to put somebody on hormone who just unfortunately, I mean, let's be honest, has a trash lifestyle because the hormones are going to be like, this is a trash system. I don't know what to do in here. Like I can't bind very well. I can't detox very well, and they're not going to feel very good. So I do also see that feedback from women who just go on hormones, but they didn't change anything. They're still, drinking, smoking, straight West Coasting, thinking that going on hormones will be a magic band-aid, and it's not.
I am stealing that somewhere somehow.
Please take it. It's my favorite line.
That's awesome.
So, yeah, so I do find that like hormones are great, but they're not magic alone. You do have to clean up your diet. You do have to make sure you're sleeping. You have to work on your stress management. You have to make sure you're pooping every day and detoxing and hydrated and, you have joy in your life. Like you still have to make sure those things are true. You can do hormones at the same time you're working on those things, but if if you don't feel good, that if the terrain is not good of your body, hormones alone probably aren't going to get you the goals you're looking for.
I'm so glad you're highlighting this because really, I mean, that's so important. John and I, and like our practice, most people who listen to this, most coaches will have a big emphasis on overall lifestyle,
Yeah.
moving the body, sweating, getting outside, going for walks, all these kind of things too. So very happy. But okay, in addition to the hormones or aside from the hormones, let's talk about maybe some other supplements someone could
Mm.
take to help ease the symptoms or just have a better transition or even in postmenopause. Something that keeps coming up is chasterberry, I believe.
Yes, chaste
Um,
tree.
yeah, tell us a bit about the function of that.
Yeah, so chaste tree is also known as Vitex agnus castus, and it's a berry off a shrubby type tree. And the scientific literature behind it is when women take chaste tree, it lowers another hormone we have in our body called prolactin. And prolactin is our prolactation hormone, which is high when you're trying to produce milk and breastfeed. But what can happen is prolactin can increase slightly for other reasons. You may not be pregnant, you may not be breastfeeding, but if you have a thyroid problem, temporary stress, if you're low in B6, if you're low in dopamine, there's a few other reasons that prolactin starts to creep up. And prolactin confuses the body. And the prolactin, when it's a little bit high, the body goes, are we breastfeeding? Are we not breastfeeding? I don't know what we're doing. So it will throw her cycle off and she won't ovulate. So chaste tree comes in and can help lower prolactin and help restore her cycle and get her to ovulate again. That's the scientific literature behind what we know about it. My observation in using it for 20 some years at this point is that I find it's like an adaptogen. So we know adrenal adaptogens like ashwagandha and rhodiola for stress. I think chaste tree is a long-time women's health adaptogen. It helps the brain communicate with the ovaries and help to restore her cycle and to get her to ovulate and hopefully naturally make progesterone again. Now, I find chaste tree works best in the early stages of perimenopause. Once she starts skipping cycles, when she skips several cycles, she's considered late perimenopause. I don't find that it works very well. I'm like, let's move on. Let's be on progesterone if that's what you're trying to go after. At this point, I can't get your follicles back, so I can't control I'm trying to, there's no way I can get the brain to tell the follicles, like, go back to normal cycles. Probably not going to happen in the late stage. So let's just move on to hormones if that's ultimately what you're after. But in the early stage, I do find that chaste tree can be really helpful for women and younger women, 20s and 30s, with
Yeah.
irregular cycles. A lot of fertility work uses chaste tree. It can be great.
I know that, like, if I'm going to diet a female hard, like to stage, right, or I need to get
Hmm.
lean, it's almost automatically going to be in there as long as they're
Hmm.
not, like you said, in those later stages. And it really, I mean, especially when they say, "Hey, I'm not sleeping very well." I'm like, "Hey, are you taking, like, at New Ethics? We've got our chaseberry, right?
Right.
The liquid form of it." And that's in there for my females that are going to diet hard. It makes a huge difference in sleep because
Yeah.
it's naturally keeping that progesterone up, better.
Yeah.
And then my ladies that are in the late stages and they have to be on hormone replacement with progesterone, like 200, at night before bed, they've all told, oh, life changing. Like, I am sleeping so well, which leads to much better fat loss. So it's
Yeah.
literally in my area, it's a game changer.
Hmm.
Just
Yeah.
adding progesterone I've seen it break a stall with people because their sleep improves and now
Yeah.
their cortisol drops and fat loss is better. So I think, and it's an amazing hormone to understand. I think it's the most important, probably, from a basic understanding for women to understand, like, quality of life and sleep. I think it's just
Yeah.
so
And
encouraging.
progesterone, it's got its name because it's progestation. So it helps thicken the uterus and makes it nice and fluffy so that implantation can occur. Now, not all women want implantation, of course, but that's like where it got its name. However, progesterone has receptors all over the body, including in the brain, but it's in the brain of a metabolite of progesterone. So what happens is progesterone breaks down into a metabolite called allo, not like the plant, but it's spelled ALLO, allopregnanolone. So progesterone breaks down into that crosses up into the brain, binds to GABA receptors, which is our inhibitory calming receptor. And that's why women go, oh, I feel so much better. I sleep better. When they swallow progesterone as a progesterone capsule, that breakdown into allo happens extensively in the liver, and then it all goes up to the brain and can help with sleep. I don't see the sleep effects as much with other routes, topical progesterone, vaginal progesterone. It doesn't mean it can't. I do have some women that go, no, I notice a difference, but they notice it better, harder, stronger when they swallow their progesterone. Now, not all women love, there are some side effects that can happen with the swallowed progesterone that some women can get. But if you can tolerate the oral, you can swallow it, then sleep. That's why we say take it at night, because it can make a lot of women feel calm, relaxed, drowsy. Some women say they feel drunk, like it just hits that inhibition and they're out.
Mhm.
Yeah.
And what about DIM? Is
DIM, yes, DIM is estrogen moving. So DIM stands for diindolylmethane, and it comes from the brassica family. So your broccoli, your kale, your Brussels sprouts. So when you chew or chop those foods, you create indole 3-carbinol. That's what you release, I3C. I3C hits your stomach acid, and your stomach acid turns it into DIM, diindolylmethane. And then DIM activates a cool little receptor called the aryl hydrocarbon receptor. And what it does is it helps move or mobilize estrogen through phase 1 detoxification better. Now, I love DIM because it will lower estrogen out of circulation and it will push it towards the proper phase 1 direction of detoxification. However, if she has low estrogen, I don't use DIM. And you have to be careful because DIM is only a phase 1 mover. You still have to get through phase 2 and then out through phase 3. Phase 3 is the colon or the kidneys. So if they're not well hydrated and if they have constipation, then I don't use DIM. Instead, I focus on hydration and I focus on regular bowel movements and then move up from there. If she's menopausal or if let's say she's young and, hasn't had a period, she's amenorrhea, has low estrogen, I don't use DIM in her either. I move on to other things. I'll use things like resveratrol. I will use broccoli sprouts, which is sulforaphane. And instead, I'll use glutathione and acetylcysteine. They also help detoxification just in different ways that doesn't lower already low estrogen. So there are a few options. Now, before women freak out and go, oh my gosh, does that mean I can't eat broccoli, kale, or cauliflower? Like I'm menopausal. No. We're not vilifying food over here. No. I mean, unless John says you can't eat those things as part of your cutting. But the food is fine. It's the concentrated supplement if you already have low estrogen. We just have to be careful of.
awesome. Thank you. Thank you so much. I think it's really helpful to know that even things like that or like ashwagandha, etc., can make a difference, can be helpful. Yeah, so I think, John, do you have any more specific questions for Carrie at this stage?
Not specific questions, just again, coming from a guy's view, the way I look at this is, I think of especially like post-menopause, and if all those hormones are low, we've put on quite a few events, featuring the M Factor movie, and they have the
Mm-hmm.
sequel that's coming out, and we've done that at Premiere U. And the biggest takeaway that I got from listening to everyone, especially the female experts that we have, was there's a way to age and go through menopause gracefully instead of just like I said, my mom
Mm-hmm.
and aunts like all that. It was so hard on them, and then we all looked at them like they were crazy. Now it's
Yeah.
understood, and it's like to me, it's things like supplementation to start, and then HRT if it applies can really kind of help you get through this stuff gracefully. And
Yeah.
I do wish you guys got some kind of medal or something like a big ceremony because now that I'm older and I see, Leslie's super chill anyway, but like she's 46, she's
Mm-hmm.
seeing some of these things happen. I am very empathetic as a
Mm-hmm.
coach and like I want to understand this better. So the way I look at it, I guess from my end, from a guy, is just there's a way to get through this more gracefully, and you all deserve that because
Yeah.
it seems so brutal. So
And it was taboo for the longest time. Women, it
yeah.
was, go in the birth control pill. Here's an antidepressant. We don't know what's wrong with you. Suck it up. That's what happens when women hit middle life. And divorce rates, are the highest, tend to be the highest at this stage in life. It might be warranted. I'm not saying that for sure. If it's warranted, it is, but it also might be part of these huge hormonal swings and nobody understands it. Nobody's getting help for it. No, it's not taught very much in medical school, although that is starting to change. So if you are noticing like you're having these big emotional swings, you're having these big body-wide symptoms, and you go to your doctor, your OBGYN, your GP, and they're like, that's what happens when you're older. You find yourself a new practitioner. At 100%, go find somebody to add to your healthcare team to who will hear you, who will listen to you, who will help you. And I think that stopped a lot of women because they're like, well, I did ask my doctor. My doctor said That's just what happens. I'm like, no, 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 no. There's so many options. There's so many ways we can go about this. And then, John, I love that you said for the men, because I've now noticed the amount of social media posts from men who were like, man, I had no idea. Like, I had no idea this is what she was going through as my wife or my sister or whatever, my own mom or what have you. And they're like, now I get it. But why wasn't this more common knowledge? And I think the men need to understand it just as much as women do.
Yeah, I that's one of the reasons and I'm not trying to keep plugging our stuff, but we started Premier U because Carrie, I feel like there's a lot of medical practitioners out there that don't understand this.
Hmm.
And I don't even know if they necessarily should because there's so many areas of expertise.
Yeah.
This is like
Yeah.
its own little area, you know what
Yeah.
I mean? We just happen to have some good people to concentrate on this. But I think a lot of women are asking for help from their doctors or MPs, and they're not experts.
Yeah.
Um, so I think finding a super qualified person is important.
Yeah, we talk about a lot how, if you have an animal, you have a dog or a cat, you take it to a vet and you don't like what your vet says. What are you going to say? You're like, okay, thanks for your time. And then you're going to get a second opinion. If you have a child and you take it to the pediatrician and the pediatrician blows you off, you're like, nope, I'm going to go find a second opinion, right? Like I'm going to go, or I'm going to, if the pediatrician or the vet is like, this is not in my scope, I'm going to refer you out to an expert. Fantastic. That's what I want to hear. If I went to a neurosurgeon, my neurosurgeon does not need to be a hormone expert, but I do need them to be a neurosurgeon expert,
Yeah.
right? And it's the same thing. So yes, you just if you're getting blown off, you're getting dismissed, thank you for your time, and we will be moving on.
Well, and thank you for your time because this has been so profoundly helpful. Again, see the show notes, look up all Carrie's information, go learn from her YouTube page, and follow along. So, I'd like to do some more of these at some point
Yeah,
in the future.
yeah,
Maybe dive down and get real specific on some other areas.
sure.
But we just appreciate you. So, for all of our listeners, we'll be back with more episodes for myself, Dr. Carrie, and Lisa. We're out of here. See you guys.